All right. Okay, thank you for the kind introduction. So my name is Vincent Larouche. I'm an endocrinologist at the Jewish General Hospital here in Montreal, and I'm an assistant professor of medicine at McGill University. Today, I was asked to speak about aggressive acromegaly, challenges for endocrinologists and patients. I'm going to preface this by saying that this is my first conference to a group of a patient association, so I try to make it, accessible for everyone. Hopefully, it will be. Et puis, je vais faire ma conférence en anglais, mais s'il y a des gens qui sont francophones, qui ont des questions à poser en français, vous êtes bienvenus pour poser des questions en français. So I'll start by going over like a definition of what is aggressive acromegaly, quote unquote. Then we're going to talk about surgery when it pertains to such cases. Same thing, we're going to talk about medical therapy, more specifically focusing on aggressive acromegaly cases. Then I'm going to talk quickly about radiation therapy and other challenges that these patients and their doctors face. And there will be a dedicated question period at the end. Good. So preparing for this talk, I was trying to see what is the exact definition of quote-unquote aggressive acromegaly in clinical practice guidelines and literature. There isn't really a clear-cut set of criteria, but I found some expert consensus points that usually raise our suspicion of aggressive acromegaly. So if a patient fits at least one of those criteria, usually we will consider that aggressive acromegaly. And one of them is enough to fit into that category. So if the growth hormone producing tumor in the pituitary gland is invasive, meaning that it invades the nearby anatomic structures like the cavernous sinuses, sphenoid sinuses, or it goes higher up and there's suprasellar extension, that's typically a more aggressive case. I'll go over a little anatomy review for you guys at the next slide. If there is a high proliferative index, so that's when the surgeon takes the tumor out and the pathologist looks at it under the microscope, they do certain specific stains, such as Ki67. That's a marker that we use to see how quickly the tumor cell reproduce. So when that is high, it means it's a more rapidly growing or an aggressive tumor. If the tumor is refractory to first-line therapy, so the usual transphaneal surgery and medication and radiation, if the tumor, despite that, grows and recurs, that's typically an aggressive case. If there's multiple local recurrences or a rapid tumor growth over sequential imaging that we do, and we see that it's growing rapidly after a year, 2 years, that's typically an aggressive acromegaly case. All right. So this is my usual spiel with patients when they first come into my office, as I explain to them that the pituitary gland, and you guys have all heard this, but just a refresher, maybe for those that are newer in the association or that were diagnosed more recently. So the pituitary gland is a small pea-sized gland located here between the eyes behind the nose, and it's the boss. It controls all the glands and hormones in the body. In terms of anatomy, you can see the way that I like to explain it for patients that it's easy to understand is that the pituitary gland is contained in a cage of bone, okay, that we call the sella turcica, that's located here. And on the sides of the wall of the cage of bone, you have compartments called the cavernous sinuses. And in those compartments, you have very important blood vessels that go through there, like the internal carotid artery, but you also have nerves that go through there that are very important for the sensation and movements of the face, right? So these are the cavernous sinuses, if you can see here on the lateral parts of the pituitary gland. Underneath the pituitary gland, so under the bottom of the cage, if you want to think about it that way, under the floor, you have the sphenoid sinuses. So these are air-filled cavity that are located, way at the back of the nose, and that's usually through those cavity that the surgeon goes through to, for lack of a better word, drill a hole in, the floor or the wall of the cage to get the bad guy out, to get the tumor out. Okay, so that's a way to explain the anatomy in simple terms. Going back to how we define aggressive acromegaly, the European Society of Endocrinology guidelines, I like how they defined it. They said that the hallmark of aggressiveness is clinically relevant tumor growth despite the use of optimal standard therapies, which entails a combination of medical therapies, surgery, radiation. Now, depending on The study that you look at, the definition that you use, the incidence of aggressive acromegaly will affect 4.5 to 31% of acromegaly patients. Now, as clinicians, when do we have a higher suspicion that a patient with acromegaly might have a quote-unquote aggressive case? Typically, younger patients, those are diagnosed under the age of 30. And why is that? I'll get back to it a little bit later, but younger patients tend to have more genetically inherited forms of acromegaly. And we know from the literature that those cases have larger tumors, they invade more laterally in the cavernous sinuses, and they're more difficult for the surgeon to remove. And these patients require multiple kinds of therapies. Now, also, another scenario where it increases our suspicion of aggressive acromegaly is when patients have symptoms of hypopituitarism. So if you have a tumor that's big enough to compress the rest of the normal gland, and then the normal gland can't do its job, and the hormones from the pituitary gland don't go to the other glands in the body, and then you're lacking those hormones, you'll have symptoms of that, and that tends to happen when you have a big enough tumor to cause that, okay? Now, if you have typically we should be using the term PITNET, or pituitary neuroendocrine tumor, where a lot of you might have heard pituitary adenomas. These are that's the old term that we used to use. When you have a giant PITNET that's more than 4 centimeters, that's very, very aggressive and very large. Now, another scenario where it's correlated with a more aggressive acromegaly is when you have very high growth hormone and IGF-1 levels, many times above the upper limit of normal. And finally, in cases where you have patients that have multiple acromegaly-related complications already, okay? Now, this is one of my favorite slides that I like to show my trainees. Just to refresh your memory, the anterior pituitary gland not only produces growth hormone, but it produces a bunch of different hormones that act at different glands in the body, and they tell these glands to do their job of producing different hormones. So just to refresh your memory, yes, we have the growth hormone, which stimulates the liver, among other things, to produce IGF-1. We have the FSH and LH hormones, which are we call them the gonadotropins. So in females, they act at the level of the ovaries, and they stimulate the ovaries to produce estrogen to regulate the menstrual cycle and fertility. For men, they act at the level of testicles, and they stimulate the testicles to produce testosterone and sperm. The TSH from the anterior pituitary gland stimulates the thyroid gland, so that's a butterfly-shaped gland at the bottom of the neck, and it stimulates it to produce the T4, T3 hormones. You're getting like a medical school 101 lecture here. And it also produces a hormone called ACTH, which acts at the level of the adrenal glands. The adrenal glands are 2 small triangle-shaped glands located on top of the kidneys. They are important for the production of various hormones, including the hormone cortisol, which is our stress hormone. And finally, the anterior pituitary gland also produces prolactin, which is a hormone that acts in women at the level of the breast to produce breast milk when they're breastfeeding. And the back part, the posterior part of the pituitary gland, is also not to be, hush-hushed. It's important. It produces a hormone called ADH or AVP, when that hormones act at the level of the kidneys to increase the reabsorption of water from the kidneys to make sure that the salt and mineral balance in the body remains stable. And there's also oxytocin, which has various roles, but among other things, it stimulates the contraction of the uterus in women in delivery. So as you can see, the pituitary gland produces a lot of hormones, and it's very important. All right, going back to aggressive acromegaly, there are some cues on imaging that can suggest to us, increase the likelihood of an aggressive case. If you have a larger tumor that's at least 1.5 centimeter, that's maybe will be a more aggressive case. If there's extracellular invasion, as you can see here on the slide, this is a very large tumor that goes way above the cella, so way above the cage. It goes through the roof, and it goes higher than the optic nerves and the optic chiasm. So those are the nerves that are responsible for our visual field. So when there's that, we know that it's going to be a more aggressive case, more difficult for the surgeon to remove. When there's post-surgery, when there's still residual tissue, that's usually what we see in aggressive cases. When we have a growth pattern where the tumor goes through the floor, of the cage and goes into what we call the clivus, which is a bony structure underneath. That's typically in aggressive cases, you'll have that, where when we have tumors that goes laterally on the sides of the walls of the cage, so in the cavernous sinuses that we mentioned earlier, that's again more aggressive cases. And there are also some signal characteristics on the MRI that will let us suspect that the tumor has a specific granulation pattern. I'll come back to that in the next few slides. So when we talk about cavernous sinus invasion, so if you remember, the cavernous sinuses are the compartments on the sides of the cage where we have the important blood vessels and nerves that pass. We use a classification system called the NOSP classification to describe how far on the side the tumor goes. So you can see here in that little picture, the pituitary gland is represented here by this pink rectangle, and the purple circle is the tumor. So you can see when you have a big tumor and it goes on the sides, it's going to encompass the blood vessels and the nerves, and that's the higher the NOSP grade, the more aggressive the tumor and the more difficult for the surgeon to go in there and remove it, okay? All right. Now on pathology, and that may be a little bit beyond the scope of this presentation, but it's very important to have our pathologists on our side in the world of pituitary tumors. There are some features on pathology when the pathologists look at the tumor under the microscope that can suggest to us that this is going to be a more aggressive case. When you have sparsely granulated tumors, and Dr. Izat could tell you a lot about that, that's typically more aggressive cases. So when we talk about granulation, we refer to how much growth hormone is produced, how much machinery is in the cell to produce growth hormone. So it might sound counterintuitive that if you have a tumor cell that produces less growth hormone, it's going to be more aggressive, where in fact, the reason why that is that, yes, they produce, let's say, a sparsely granulated tumor produces less growth hormone, but it also has less receptors for somatostatin. Now, somatostatin is one of the two hormones from the hypothalamus that regulate the production of growth hormone in the pituitary gland. So somatostatin is also called growth hormone inhibiting hormone. So if you have less receptors for the hormone that diminish the production of growth hormone, then it's going to be a more difficult tumor to control with medication eventually, if that makes sense. We know that it's going to be less responsive to medical therapy like somatostatin analog medication. If you have more primitive tumors as well, so these are less well-differentiated tumors, some of them include PIT1 lineage tumors, acidophil stem cell tumors, mixed somatotroph lactotroph tumors. We know that these are more aggressive and will respond less well to the traditional surgical and medical therapy. So that we talked about that. We talked about the proliferation marker. Another aspect that pathologists look for on the pathology of a pituitary tumor is the presence or absence of a p53 mutation. So p53 is a protein that suppresses tumor growth, if I can put it like that. So when that is mutated, you know that it's going to be a more rogue and aggressive tumor. Now, what about genetics? I know you had a very interesting talk about that this morning, and I'll just go quickly over it. So for your information, 5 to 7% of cases of acromegaly/gigantism occur in a family or inherited setting. And if you look at patients diagnosed under 30 years old, that is up to 20% of patients, okay? Common mutations that may cause acromegaly include MEN1 syndrome, or as we like to teach our trainees, the 3P syndrome, right? Because it encompasses pituitary adenomas or pituitary tumors, parathyroid hyperplasia or parathyroid tumors. So the parathyroid glands are 4 small glands in the neck that are responsible for the balance of calcium in the body. And those patients can also have pancreatic tumors, so hence the 3Ps. So it can happen in that syndrome. It can happen in another genetic disorder called familial isolated pituitary adenoma. So that's a mutation called the AIP mutation. And that was the mutation that the Irish giant families had. So if you heard about that. So typically patients with those genetic syndrome will have more invasive, larger tumors. They will require multiple different kinds of therapies. There are going to be more resistance. Other mutations that can cause acromegaly, I put it there for your general culture, X-linked acrogigantism, MEN4, which is similar to MEN1, but it's a different mutation. McCune-Albright syndrome due to the GNAS mutation. So we've seen that there's different aspects of a case in acromegaly that can increase our suspicion of an aggressive acromegaly case. We mentioned the different pathology subtypes, the expression of somatostatin receptors, the proliferative markers on pathology, large tumor size, a high NOSP grade, meaning that they go laterally in the cavernous sinuses, the rapid tumor growth, the young age at diagnosis under 30, the very high growth hormone and IGF-1 levels, and the presence of a genetic mutation. Okay? Good. So now let's talk about the treatment and particularly putting emphasis on those different difficult aggressive acromegaly cases. So as you've probably discussed this morning, and Dr. Langlois gave a very good talk this morning, and hopefully I'm building on her foundations from this morning. So as you know, acromegaly is first and foremost a surgical disease, as much as in terms of therapy, that's the mainstay. So the best case scenario in acromegaly is to do a transsphenoidal surgery, a transsphenoidal resection, where the neurosurgeon goes through the sphenoid sinus and removes the tumor, hopefully entirely if possible. With transsphenoidal surgery, what we know from the literature is that the growth hormone secretion normalizes in 90 to 100% of cases with microadenomas. Again, by microadenoma, we mean tumors that are less than a centimeter. But when we talk about macros, unfortunately, that cure rate falls to 50-60%. And in terms of complete tumor resection, when we talk about microadenomas, experienced neurosurgeons will be able to achieve complete resection in 80-90%. But with macros, that falls down below 50%, unfortunately. For those that have very large tumors, if you remember the picture that I showed you earlier, it's still recommended to do debulking surgery in those cases, even though we know that the surgeon is not going to be able to remove everything. And the reason behind that is we know that even if, let's say, the surgeon is able to remove 75% of the tumor, if 75% of the tumor has been removed, they will respond better to therapy afterwards. So that is recommended. And IGF-1 may take up to 6 months to normalize post-op. Now this on the right-hand side, it's very interesting. You see what they do in transsphenoidal surgery. So this is the typical surgery that the neurosurgeon performs to remove the pituitary tumor. So you can see that they go through the sphenoid sinus. So that's the air-filled cavity that's under the floor of the sella. And we can see here in sort of turquoise the pituitary gland, and you can see the tumor here in yellow. So they drill a hole and remove the bad guy, okay? So specificities of transsphenoidal surgery in aggressive acromegaly cases. So typically the patients have already had at least one surgery. They may require a second one if it's accessible for the surgeon and there's residual tissue that they think they can go remove. In such cases, the surgical approach might need to be a little bit more invasive. So if the residual tumor is on the side in the cavernous sinuses, the surgeon might try to go remove it, remove the residual tissue going around the blood vessels, around the nerves, but obviously there's a higher risk of complication with that. And if you remember the picture that I showed you earlier, a tumor that's very large and very high up, the surgeon might just not be able to go after it from below, from transsphenoidal approach. So they might need to do a transcranial resection. So that's unfortunately cracking the skull open and going from up. It's rare, but in cases like that, they might have to do that. One point I want to emphasize today is how important a multidisciplinary approach is in pituitary tumor and acromegaly. So you want to work together, your endocrinologist with the neurosurgeon, the ENT surgeons that also help for the first part of the surgery when they go into the sinuses. So that's very important. It's primordial to work with your radiation oncologist when the patient requires radiation, and to have excellent neuropathologists that work with you in such cases, and obviously with the patients and the families as well. We know from literature that patients tend to have better outcomes if they go to a more experienced neurosurgeon. Obviously, the success rate of the surgery will depend on the size, the location of the tumor, the invasion in the adjacent structures. But we also know from literature that if the surgeon performs, the more surgery the surgeon performs per year, the better the outcome of the patients will be. Okay, going over medical therapy. So we have three main classes of medication that we use in acromegaly, and I'm sure you guys are well aware of that. One is the somatostatin analog. So if you remember, somatostatin is the growth hormone inhibiting hormone. So what we do here is those are monthly injections, intramuscular injections, or sometimes deep subcutaneous that the patients receive. And the idea is that if they have residual tumor after the first surgery, those injections are going to go bind to the receptors on what's left of the tumor, and they're going to prevent it from producing growth hormone, essentially. We have octreotide LAR, also known as Sandostatin LAR. We have lanreotide, also known as somatulin autogel. Those are our first generation somatostatin analogs. And we have the more recent, sexier kid on the block, pasireotide, also known as Signifor. So those are the main somatostatin analogs that are used. Rule of thumb, most of the time, it's the first-line medical medication that's being used in acromegaly after surgery when you still have excess growth hormone in IGF-1. You also have dopamine agonists. So those are pills, either once or twice a week or everyday pills. Actually, this is a treatment that most of the time we use in prolactinomas. So that's a different kind of pituitary tumor where you have a tumor that secretes prolactin. What happens in those cases is we use those pills to normalize the prolactin hormone, and it makes the tumor shrink over time. But in some cases, we use it in acromegaly, and I'll get back to that. We have cabergoline, also known as Dostinex, or bromocriptine, also known as Parlodel. And finally, the big gun medication that we use sometimes in more refractory cases is the growth hormone receptor antagonist pegvisomant, also known as Somavert. So that's a daily, most of the time, daily injection. And what that drug does is it works on the liver. It binds to the growth hormone receptors that are on the liver. So the patient's own growth hormone cannot bind. So it blocks it, and therefore it reduces the IGF-1 production. Okay? So we talked about somatostatin analogs. Octreotide and lanreotide are the first generation ones. They will reduce tumor volume in 50 to 60% of patients. They will normalize the IGF-1 in 40 to 75% of cases, more so in the densely granulated than the sparsely granulated tumors. If you remember, the densely granulated ones were the ones that, yes, produce more growth hormone, but had more receptors for those drugs. So they work better in those tumors. And we know that debulking surgery is associated with the better efficacy of the somatostatin analogs from literature, right? So those that have very large tumors, let's say 75 to 80% of the tumor was taken out, whatever's left is going to respond better to the medication than if the whole tumor was still there, okay? The second generation, you have pasireotide, which is more effective than octreotide lanreotide to normalize the IGF-1 and to reduce the tumor volume. But the downfall of that drug is, unfortunately, it causes a lot of diabetes and worsens the control of those that are already diabetic. There was one trial in which they took patients that had poorly controlled acromegaly after surgery and on those injections, and they switched them to the pasireotide injection. So those were already difficult to control cases, and 15 to 20% of them actually achieved that biochemical control, but 50 to 60% became diabetic. So it's a catch-22 to keep in mind. Other side effects that you might have with those drugs, so they increase your risk of gallstones. They might cause gastrointestinal symptoms such as diarrhea, nausea, abdominal pain. They can cause a transient increase in blood sugar, worsening of the diabetes control in those who already have diabetes. They can lower the heart rate a little bit. They can cause hair loss. If we look at pros and cons of those drugs, what's good is they don't affect the rest of the pituitary hormone, so there's no hypopituitarism. It's a monthly injection. And you have a reduction in control of the tumor size, and we have symptom control with those drugs. The disadvantages for some patients that are maybe more needle phobic, for instance, this is an intramuscular or deep subcutaneous injection. You have the side effects that I mentioned earlier, the cost, and then the number that I'm quoting here is from an article that's a couple of years old, so it's probably higher than that nowadays, $27,000 US a year, probably more than that now. And the efficacy is up to 60%. Most of the time, when we use those drugs is after the patient has had surgery. In some cases, we might use it, quote unquote, neoadjuvantly. And what do we mean by that? In some cases, we use it before the patient has had surgery. If you're in a hospital where there's a long delay and it takes a year before the patient has the surgery, then you want to do something, right? So you might use it in such cases. Or we know from literature that another scenario where that might be useful, those drugs, is when you have a patient that has a lot of airway disease and airway swelling, and it might be a difficult intubation for the surgery. And in cases like that, we might use the somatostatin analog to reduce the swelling in the airway and to decrease the risk of perioperative respiratory complications and to make the intubation a little bit easier for the anesthetist. Pegvisomant, Somavert, I mentioned earlier, so that's the growth hormone receptor antagonist. It binds to the growth hormone receptor at the level of the liver. It blocks the binding of the patient's own growth hormone, and it will cause a decrease in the IGF-1 and the production of other growth hormone-dependent proteins. Very good drug, but it comes with a certain burden for the patient because we're talking about a daily injection subcutaneously. It is very effective. In the initial studies that were done with it, it normalized the IGF-1 in 97% of patients. However, in the real world studies that are the ACRO studies, it was about 73.2% effective at normalizing IGF-1, but in that one downfall in those studies is that sometimes the patients were a bit underdosed. The main side effect that you'll encounter with pegvisomant is injection site reaction. So the patients may have a little bit of pain and swelling at the site of the injections. But the one that we worry about a little bit more as endocrinologists and we follow a little bit more closely is the liver enzyme elevation. I wouldn't worry too much about that as patients because it hasn't been reported that a patient took pegvisomant and had fulminant liver failure and required transplant or something like that. Most of the time, it's a mild liver enzyme elevation, and we can manage it by decreasing the dose or increasing the interval between the injections, and it typically gets back to normal, okay? The advantages, it's highly effective. It doesn't cause hypopituitarism. It's excellent for diabetes control. Disadvantages, as I mentioned, a daily injection, the risk of liver enzyme transient elevation, the cost, that one is $60,000 a year and probably more. And there is in literature a theoretical risk of increased tumor size of about 7 to 8% because the pegvisomant acts in the liver, right? It doesn't do anything for whatever's left of the tumor in the pituitary gland. But from the studies, obviously that it was difficult to say if it was from the drug itself or if it was because the drug was used in very aggressive cases where, it was an aggressive tumor with an aggressive biology and it would have grown anyways. So that's a question here. Dopamine agonists, so as I mentioned, those are the pills. So either cabergoline, which is a pill that's taken once or twice a week. Bromocriptine is a pill that's taken daily. We rarely use those drugs, but in some cases it might be useful. And it's also, those are medications that are very benign with very little side effects. The advantages are that they're taken by mouth, they act rapidly, they don't cause hypopituitarism. We use them in cases like, let's say we have a patient that has had surgery as residual tumor and the IGF-1 remains a little bit elevated, but very mildly, like less than 1.5 times the normal. In cases like that, we might consider those drugs because they're very easy for the patient to take. Or in the case where you have a tumor that secretes both growth hormone and prolactin. For those tumors, they work well. The success rate is not impressive, but we try it, 34, 52%. Now, if the patient decides to go on Google and make a Dr. Google out of themselves, they might find some worrisome articles about the fact that those drugs might increase the risk of affecting the valves of the heart. It used to be a concern in the 70s, 80s, 90s when we used to use much higher doses of those drugs. However, more recent articles have shown that it's actually quite safe. And with the low doses that we use nowadays, you don't run into those issues. All right, radiation. So typically we use that in growth hormone producing pit nets that are not controlled or still growing despite surgery and medical therapy. There's different techniques. I'll spare you the details because that's even beyond me. You have more classical old school techniques like external beam radiation therapy. And what we use nowadays is more focused radiation towards the pituitary gland and the residual tumor. So the subtypes of radiation therapy that are used are typically stereotactic radiosurgery versus fractionated stereotactic radiation therapy. The advantages of those techniques are that it works very well to control the growth hormone secretion, and sometimes it will stop tumor growth and cause even a shrinkage of the tumor. The side effects are that it works very well for the growth hormone, but it works very well for everything else in the pituitary gland. So there's a high rate of the patients developing hypopituitarism down the line. So they will start having not enough of the other pituitary hormones, and then that also has its own consequences. There are also some visual changes that can happen with radiation therapy. Typically, we try to not give radiation therapy if the tumor is closer to the optic chiasm, closer than 3 millimeters, because even though the radiation is very targeted, sometimes if it goes a little bit around the tumor and it affects the nerves, then it might affect the patient's visual fields and vision. And there's a risk of secondary malignancies, and I'll get back to that. The more modern techniques tend to cause earlier biochemical control and less hypopituitarism. So I mentioned that for stereotactic radiation therapy, the remission of growth hormone excess is about 65.4% after 61 months. So it works, but it takes time to work and to knock off the growth hormone. But at 61 months, so 5 years, 30% of the patients had hypopituitarism. And if you look at 10 years down the line, because that can take a long time to affect the normal pituitary gland, the risk of hypopituitarism is more than 50% at 10 years down the line. And the risk varies depending on the hormone you're looking at and depending on the study that you're looking at. As I mentioned, other possible risks with radiation, it can cause cranial nerve palsy. Let's say that if radiation is given to a tumor that's in the cavernous sinuses, where you have all the nerves that are responsible for the sensation and movement of the face, it could cause damage to those nerves if it was given in that area, let's say. It can cause blindness. It can cause, to a certain extent, memory neurocognitive defects. There's a risk of secondary tumors of 2-3% at 20 years. So those are brain tumors that would develop in the area around the pituitary gland because it was radiated. So that includes meningiomas, astrocytomas, glioblastomas, sarcomas. And there's also a risk of stroke and cerebrovascular mortality with radiation because radiation makes the blood vessels very fragile in the brain, so more prone to bleeding and clotting, okay? But I want to say these are risks that you need to know when you get into radiation, but their percentages are quite small. But it's never zero. As we've mentioned multiple times today, so patients with acromegaly have a higher mortality and morbidity, mostly due to cardiovascular, pulmonary, and cancer causes. Those that do the worst are those with acromegaly and coronary artery disease or diabetes. But we know that when the growth hormone and IGF-1 levels are normalized, the mortality rate will slowly but surely fall to the general population. Other comorbidities of acromegaly, one of my take-home messages, get a colonoscopy. Patients with acromegaly are at high-risk group for colon polyps or cancer. So it's not fun, but do it, okay? As soon as diagnosis. If your doctor finds a thyroid nodule on exam, they should have a low threshold to order a thyroid ultrasound because there's a higher risk of thyroid nodules and even thyroid cancer with acromegaly, so you want to get that done. In terms of hypopituitarism, so the deficiencies in the other pituitary hormones, so the doctor should question you and test for those routinely on blood tests when they see you. They should not look only at growth hormone and IGF-1, but they should look at all the other hormones of the pituitary gland. And when they are missing, they should be replaced with hormonal replacement. So that's, let's say, hydrocortisone if they're missing ACTH and cortisol, testosterone in men that have a low testosterone, estrogen, progesterone in premenopausal women, levothyroxine or synthroid when people have a deficiency with the thyroid hormones, desmopressin or DDAVP when they're lacking the ADH hormone from the posterior pituitary gland. And that's a little bit controversial in the literature, but if someone has had acromegaly and they were treated and they are now growth hormone deficient, some people would advocate for growth hormone replacement, but I haven't done it yet. And also, acromegaly patients are at high risk for sleep apnea. So if you have symptoms, your doctor should have a low threshold to order a sleep study. Okay, so if you snore or your partner hears you snoring, or you wake up in the morning and you feel unrefreshed, or if you absolutely need to take a nap in the afternoon, or if you wake up at night gasping for air, get a sleep study, okay? Bone health is another potential comorbidity that you might have with acromegaly. So we know there's a higher rate of spine fractures in acromegaly. It's worse if the growth hormone excess is not well controlled. It's significantly associated with hypogonadism and longer duration of the disease. It sounds weird, right? You would think acromegaly, there's a lot of bone and cartilage being made. Well, in fact, what happens is we know patients with acromegaly have a higher bone turnover, and if you do a bone density test to screen for osteoporosis, they might not have a low BMD, but we know that the bone that's being made so quickly is not a very good quality bone. So there's still a risk for fracture. That's not necessarily appreciated by the bone density. All right, I'll pass that for the interest of time. Okay, so in conclusion, there's no clear consensus definition of aggressive acromegaly, but we've gone through some features that increase our suspicion as endocrinologists that a patient might have a case of aggressive acromegaly. We've talked about certain features on pathology. When we are faced with the younger patients, the presence of a genetic syndrome, when a patient has a larger and more invasive tumor, when it presents with local and multiple recurrences, if there's a rapid growth of the tumor on imaging, if it's refractory to standard therapies, if you have very, very elevated GH and IGF-1 levels, if you have concomitant hypopituitarism, if there's multiple comorbidities. We've seen that in cases of aggressive acromegaly, there are specific challenges that these patients face regarding surgery and medical therapy and radiation therapy. I want to, again, emphasize how important it is that your endocrinologist and your treating doctors screen early and often for the metabolic and cancer comorbidities that you have in acromegaly, because the earlier we diagnose, the better the outcomes will be. So that's your colonoscopy, your thyroid ultrasound, your maybe your echocardiogram, your sleep study, and so on and so forth. And again, the importance of a multidisciplinary approach is crucial here in the world of pituitary disease with neurosurgeons, endocrinologists, ENT surgeons, pathologists, nurses, radiation oncologists, and obviously the patients themselves and the families. And that is it. I know I talk fast. That was a lot. Thank you.
Thank you. On? Yes. Sorry. Thank you so much for that. Deanna just had to step out for a moment, so you're stuck with me. And is there any questions from the group? Yes.
Yeah,
JD.
I have a quick question. There are some neurosurgeons that are doing more aggressive pituitary surgery in the cavernous sinus. I believe it's the median wall. I'm wondering what you think about that, and if you're obviously familiar with it, and if what's your opinion on those procedures?
I've heard of that, and I guess it depends with each neurosurgeon's level of comfort and training. And I guess the more they do, the more experienced they are at it. But it is for sure the cavernous sinus is an area that damage can be done in terms of blood vessels and nerves that are passing through that area. So they need to be good to be able to do it. Yes.
If I can comment on that, we have 2 neurosurgeons in Quebec City, and the one that arrived a few years ago, he was trained to do bone extension, bone resection, and the first one is like has never done it before. I think it's a kind of a new technique, and hopefully it will lead to better result. And he looks at the walls very carefully during the surgery, and if he sees that something is not quite right, if it thinks that the walls is a little suspicious, he's gonna cut a frame in the wall and take it with him. And of course, there are some side of the cages that Vincent described that are more dangerous for a bleeding or something, very serious complications during the surgery. But some walls are not that bad to make a frame and take it. So I think it's very interesting.
And just to add on what Dr. Domingue was saying, I know the neurosurgeon I work with is quite comfortable going into the cavernous sinuses more than maybe other of his counterparts. But it also boils down to having a very good preoperative imaging to know exactly what they're dealing with and where and how they can remove it. Yeah, but very good question. Thank you.
A good question and a great presentation, Vincent. Very happy. You did a great job. I do want to mention a word of caution, though, about the cavernous sinus. I've lived through this now for almost 40 years, and I can tell you we've gone through waves. And I don't know whether you have a picture of it, Vincent, when you were showing KNOSP staging. This is very, very important, and I think actually probably speaks, maybe if you just stop here. So it's important to understand why there is such a high incidence of patients needing medical therapy. And Vincent did a great job at telling you, the closer truth is that about half of patients will end up requiring medical therapy. And the reason being that growth hormone cells sit on the sides. That's where they normally are located. And when they grow, they don't have to be very invasive to get not just in the cavernous sinus. That's not the problem. The problem is that it goes between the carotids. So if you look at those 2 red circles on the sides, those are the loops of the carotids that supply blood to your brain. In between those 2 loops are the nerves that supply the movement of your eyeball, so you can keep your eyeball open and being able to move your eyes. So when a tumor grows, interestingly, most of the time when it's a really good tumor, reasonably well-behaved tumor, it actually is able to get through between the vessels and the nerves and leaves them respectfully intact. You don't lose your ability to be able to see, and you don't get a stroke. If you get a bad tumor and you violate that tumor by trying to be a hero, then you will end up with potentially a very major stroke. And if it's on the right side and you're left-handed, that can have major consequences. So I caution the aggressive treatment that's overzealous, because we've been through this. It's not a matter of getting access. We can get access. It's a matter of the tumor that has gotten that far. It has intertwined itself with the nerves and the blood vessels that you're really asking for trouble. That's number one. Number two, one of the things that I think has improved quite significantly is that we can now do gamma knife with greater precision, that we can actually target that area of disease without having to injure the nerves. And I think Vincent did a good job at pointing that out as well. That probably is safer, and I would be much more in favor of taking the safer approach rather than trying to do more and end up with disasters.
Yeah, thank you for the great point, Dr. Izat. Yes, sometimes it is safer to just leave a little bit of tumor there when you know that you can control it with medical therapy or radiation, and that surgery is very risky. That always remains a dynamic discussion between the patient, the endo, the neurosurgeon, and the patient themselves.
Over here.
Thanks for a nice review. I have a comment and a question. I think it goes back again that it's really important not to get a neurosurgeon. It's really important to get an inexperienced pituitary surgeon. If you look at all the data, we can go on and on about everything. At the end of the day, that's what it is. We need our surgeons, right? We need a really good pituitary surgeon. Not only that, but it's doing a lot of them.
Yeah.
Right? So again, that's for advocacy. That's why I wanted to point that out. I think we all know that. The second thing is, this is a practical question, again, for advocacy. Patients who undergo radiotherapy, which we're using probably not as much as we should be because it's safe with gamma and cyber, is that patients are often bridged medical therapy. They might be on an somatostatin analog or PEG or cabergoline in some cases. And I think the literature bounces back and forth. A lot of its practical answer is that should they be holding their medical therapy peri or pre-radio surgery? And I think patients often don't know about this. And sometimes we may not tell them because they go see a rad onc and we're sort of out of the loop because we're seeing them in 4 months, for example. So what advice would you give to patients who are on medical therapy pending radiosurgery? Holding or not holding the therapy? Or if so, how long and for when to restart it again?
I'll be honest. I would have to discuss that with the radiation oncologist to see how long he wants the patient to withhold the medical therapy before radiation. I'm not sure of the exact duration. I would need to check that. Typically, we kind of leave the radiation oncologist to make that decision, or we make that decision together. I don't know, what do you do in your center?
So the literature, I've looked into the literature here, and it's not very good. And Dr. Izat and I have spoken about that too before. And there's varying schools of thought. So the most recent literature, again, it's not very good. It said that it probably doesn't make a difference. So I'm sort of going in between. I'm holding it for a while rather than the full term. But it'd be interesting to see what the other endos are doing because I don't think anyone really knows, to be honest. There's a theoretical risk.
It's very gray zone.
It's very gray.
It's really not clear
cut. There's a theoretical biological possibility risk that if you don't hold medical therapy, the radiosurgery won't work as well. But it's theoretical. But we don't know about the clinical effects, right? So that's why I've sort of compromised because I don't know either. And at the end of the day, you want to do no harm and maximize benefit.
Exactly. And you have to keep also in mind, like, what are the risks of holding medications for, 4 weeks in someone that's on somatostatin analogs and pigvisomant and isn't well controlled on that. So if you're going to take it out for a month, risks and benefits.
Mark, sorry, do you mind passing the mic down to Sally?
Oh, okay. I was going to ask just very quickly. So the classic dogma has been that you should never use anti-cancer therapies when you're giving radiation. That stems from the concept that the anti-cancer therapy is restraining the tumor from growing and as such is diminishing the ability of the radiation to cause damage to kill a tumor. However, this does not apply to this disease. These drugs are not targeting a rapidly growing tumor where the DNA is actually replicating. The data is negligible, if at all, and I would argue very strongly that interruption of treatment, especially in these resistant cases that get to a point where they require this type of treatment, probably would be more deleterious, and I would carry through. That's number one. Number two, even if you were to stop it, as you know, the carryover effect is for months and months and months. So it would be entirely inappropriate in my mind that those select patients would be compromised for the purposes of radiation. We don't.
I've continued patients through radiation.
So I'm one of those cases. So I had 2 surgeries. The second surgery, they thought they took everything out to stop my medical therapy. 4 months later, IGF in the roof. And then they did radiotherapy after that. But I'm still, after that, still in medical therapy. because it's only been 2 years since I've had my radiation. So hopefully it's not growing, which is great. Hopefully we'll be able to get off the medication soon or one day.
Yeah. It's not always easy. And sometimes, like, I've had cases like on imaging, it looks like everything is good, but there are still some tumor cells left that they're working hard and they're still making growth hormone. And you still have to do medical therapy and radiation, even if it looks clean on imaging or it looks stable. But yeah. Yeah. Challenging. You fit in that category, I can tell you. Yes.
Any further questions? All right, my turn then. I've got a quick one. And I know we did discuss this last year, but there are a number of new folks in the room. With the increased knowledge we have around the types of tumors and the staining that can get done, are you seeing any push towards more targeted treatments, like bypassing the medications that are unlikely to be effective to just increase quality of life sooner?
I wish I could tell you yes. But it really depends on, there's a matter of access to the medication and our provincial, the provincial plan of what is covered in your province. So I'm going to give you an example. Here in Quebec, if we want to have access to growth hormone receptor antagonists, we need to try somatostatin analog. Even if we know that because of certain pathological features on the patient's tumor that it might not work, you still have to try it. At least a couple of months. And then if the IGF-1 remains elevated, then you can ask for the government to pay for pegvisomant, but you cannot upfront ask them to cover pegvisomant. But when we do, though, we get accepted quickly. But unfortunately, there's a lot of practical step-by-step approach and hurdles that we have to go through.
Yeah. Be nice to see that change over time, but we'll get there. Oh, sorry, another question at the back.
I think that we go faster on the next step. If we believe that it's a tumor that is resistant, we won't wait 6 months before we switch to our second or third line. I think we go faster.
Yeah.
Because the argument that we have to deliver to the insurance company, it's not related to time. So, okay, we have one IGF-1 that is higher than the normal, so it's not working. So we go faster, I believe.
Yeah.
Yeah, it's unfortunate we talk about personalized medicine and individualized medicine, but the government doesn't believe that, right?
Exactly.
They don't know the disease, and Health Canada, we know, is pegvisomant is now indicated for someone with a sparsely granulated tumor, SST2 negative, man, hyper T2 on MRI. It's actually not even second-line therapy. PEG is first-line therapy, right?
Exactly.
And they have diabetes, it's even more first-line. So I think that's where we have to be advocates also, is really pushing for quote-unquote true first-line therapy. Because at the end of the day, you're wasting more money. The patient's using that somatostatin along. It's like water for them, right? There's no receptors. It's not going to work. So it's really unfortunate that we talk about this. But we want to push for real therapy, but it's the hurdle is, or the rate-limiting step is the people who make the decisions who have no clue about what acromegaly is, unfortunately.
Exactly.
Okay. Everyone's good? All right. Well, a huge thank you, Dr. Larouche.
Thank you.
Really appreciated that.